come to this next session on rheumatic fever. It's a very important topic. Rheumatic fever is emerging again. We see more and more cases in our day-to-day practice, and guidelines, they have changed the guidelines in 2015. To discuss everything, we have an eminent speaker from India who has done a lot of work in rheumatic fever. Professor R. Krishna Kumar, he is the clinical professor and head of pediatric cardiology at Amrita Institute of Medical Sciences. And he is my trainer as well. So, over to you, Dr. Krishna Kumar.
Good evening again, and thank you for choosing a topic that's very dear to my heart. I have a few disclosures in connection with this, which essentially none of which is financial. I would try and cover some areas, because this is a topic I'm sure it's being discussed after a long time. So I'll try and discuss what's new with the epidemiology of the disease, what is new about the diagnosis, a few case studies which will illustrate some of the aspects of what I have spoken about. The definition you're all familiar with. It's basically rheumatic fever is not infectious. It's an inflammatory disease that follows an infection with very specifically group A beta hemolytic streptococcus. Now, I have written throat infection because that's the commonest cause, but it is now believed that even skin infection can do it in selected circumstances. So there are some conceptual changes. Our mental model for rheumatic fever was linear. Streptococcal infection, rheumatic fever, chronic rheumatic heart disease, and then complications. Now that's changed. You don't actually have a lot. You can have a subclinical inflammation going on that directly leads on to rheumatic heart disease without discrete episodes of rheumatic fever. Now that's increasingly apparent through the research that's been done in the last several decades, but perhaps also that there might be a real change in the way the disease manifests. So this is something that we need to embrace, but the triad hasn't changed. This classic epidemiologic triad of host, agent, environment applies beautifully to rheumatic heart disease. The agent, if we all know about it, is group A beta hemolytic streptococci. We haven't been able to identify rheumatogenic strains. Sore throat, there is a clear association. Skin, perhaps. Particularly in Australian population, there is a growing belief that skin infections may be associated. But nobody knows the basis of rheumatogenicidity. Host, children, 5 to 15 years, most vulnerable. You can have exceptions like you have everywhere in medicine, but recurrence beyond 40 is really rare. So you can stop prophylaxis potentially at the age of 40, and that's something that's increasingly being practiced. Genetic link, lots of talk, lots of papers, but no real substance added to those theories. No question, it's a disease of poverty, and it's a disease of access to healthcare. That's really important. It's perhaps not as much related to overcrowding as we would like to believe. And I'll show you some data. And there is, of course, some seasonal variations that we don't see in our parts of the world. More importantly, the disease was on the decline. Everywhere, particularly in the low and middle income countries which have those parts that have shown improved healthcare, there is a decline. There's no question about that. But the disease is still prevalent in pockets. It's a very nice study from Shimla. My colleague did it. He did 2 surveys, 1991, 2008, and lots of things improved in the state of Himachal Pradesh, and almost in that period, he showed a very remarkable decline in the prevalence of rheumatic heart disease. So clear association shown with human development status, and I think that's something that you see everywhere. I'm certain that you saw it in Sri Lanka as well. So the disease has got sequestered in populations that are deprived. So in Australia, for instance, amongst the indigenous population and non-indigenous population, there is a huge difference. There is a 70 times likelihood of disease in the ones who are indigenous versus non-indigenous. So there's a very marked difference. And even in India, there's a gradient. You can demonstrate. Dr. Arita Saxena showed that urban versus rural poor. and you have this gradient in prevalence of rheumatic heart disease. This is through an echo screening project. So who is affected by rheumatic heart disease? Clearly, the rural poor and the marginalized populations. And the problem is we healthcare professionals are increasingly looking to take care of the affluent, the urban middle class. So this group has really slipped out of our collective consciousness, the poorest. That's where rheumatic heart disease is. About the pathogenesis, the slide shows it very elegantly, but it's essentially what we've understood and known all along, that there is streptococcal infection on the pharyngeal epithelium that activates B cells and T cells. The B cells produce antibodies which are cross-reacting with heart, brain, joints, and skin, aspects of those tissue, and you have the manifestations. And of course, even the T cell participates in this process. What actually happens in rheumatic heart disease is widespread endotheliitis, that is inflammation of the endothelium. And you have everywhere where there is endothelium or lining that gets inflamed. And once that gets inflamed, in this process, it triggers a whole sequence of events. But what is remarkable is that this endothelial inflammation completely subsides and heals, with one exception. And that exception is heart valves. The heart valve, despite everything, can get injured, and permanently so. So Dr. Tandon, my mentor, made this very clear observation that heart valves are structurally unfortunate because they have a core of connective tissues covered by 2 layers of endothelium. Now that particular structure makes them vulnerable. So these cross-reactive antibodies damage the endothelium, and that results in expression of adhesion molecules on the endothelium that leads to T cell migration, macrophage attachment, and they migrate to the core of the connective tissue. Once they migrate, there is neovascularization, inflammation, and that triggers a vicious circle of events which leads to scarring. Doesn't happen anywhere else, only in the heart valves. Diagnosis, what's new? Jones criteria has changed. It's still not a gold standard. It's a good guideline. And it's basically designed to avoid overdiagnosis in regions where the disease is rare, underdiagnosis in the regions where the disease is common. There are 5 major criteria, as always. 3 are common, 2 are rare, 4 minor criteria, and 3 exceptions, with essential criteria of identification of relationship with streptococcal infection. So the revised Jones criteria in 2015 made had these 3 unique features, which is that they distinguish between low and high risk populations and applied different criteria for those populations, included subclinical carditis, and made it somewhat liberal to diagnose recurrence. So what is common for both these populations is that if you have to have a first episode, then you need 2 major plus 1 minor, 2 major or 1 major plus 2 minor. If you have recurrence, then you could also have 3 minor. It's always essential to show evidence of streptococcal infection. So they define low risk populations as rheumatic fever incidence less than 2 per 100,000. Rheumatic heart disease prevalence less than 1 per 1,000. So these were the criteria, and the differences were really in the fact that you were more liberal with high risk population. So you included polyarthralgia or monoarthritis in this group, and also you were not very strict about the fever or the ESR. You were able to apply a more liberal set of criteria. You were relatively strict for the low risk population. That's understandable. And these criteria maybe allows a better distinction in and identification of rheumatic heart disease. So subclinical criteria is very important. This is something that we've all come to accept, and some of us took some time to accept it, but it's important. Echo positive but clinically silent. It's very common. And strict Doppler criteria are important. Echo is now included, but it's not a must. If you don't have echo, you can still use clinical criteria. Strict application of diagnostic criteria are mandatory, I'm going to show you some case examples. So here is an example, and all of you can identify this, of this girl who has such classical manifestation of rheumatic chorea. Something when you see it, you'll remember it forever. So this is something that, is very unique, and you should be able to identify it, particularly it's neurologists who are getting to see it more often. It's commoner in female. It's got a long latent period. It's rare in adults except in pregnant women. And every voluntary muscle can be affected. You also have inappropriate behavior. And of course, this is transitory and completely resolves. Another example. This is a 8-year-old with, classic, what looked like rheumatic fever, with high-grade fever, migratory polyarthritis, and cardiac symptoms. And when we examined him, he was well when he came to us by the time, but definitely he had features of rheumatic fever in form of a pericarditis, severe mitral regurgitation. But what we were taught in my formative years is to look for subcutaneous nodules. So here you can see over the spine, these protuberances, which are over the scapula, over the knee, which is folded, and over the elbow, as well as you can see in this particular instance, and in the forehead as well. So these are very classic subcutaneous nodules, which may be missed because people don't look for them carefully enough. It's very important to be able to identify them, and they help in diagnosing rheumatic heart disease because they have a very high sensitivity and specificity. Of course, this patient had severe mitral regurgitation, and that is a result of valvular inflammation, which can be seen in pathologic specimens as verrucous vegetations, which have small, tiny, adherent vegetations that you don't see on echo clearly. You just see them as a nodule or as a garland appearance in the valve, which is very, very typical, considered very typical. And then, of course, these patients have a prolonged PR interval, which has got nothing to do with carditis, but it's a useful diagnostic criteria. This patient, of course, did well after hospitalization and received steroids because of the carditis and received diuretics, and patient was discharged on day 5 and his subcutaneous nodules completely disappeared. So that's another thing that's really typical of these patients, is the way it disappears. That again adds to the diagnostic likelihood. Arthritis is commoner in older patients, and it used to be more common than what we're seeing now. But you don't necessarily get that sequential classical migratory polyarthritis in everybody, and they have a lot of mimics, particularly post-streptococcal reactive arthritis, which may happen much earlier after streptococcal infection and may not have that dramatic typical migratory pattern and may not be as painful as what you see with rheumatic fever. Of course, you won't have other manifestations. I won't spend too much time on this, but the basic goal is to eliminate streptococcus. So you have to give penicillin early, and we prefer to give benzathine penicillin in these patients. Symptom relief, it's not mandatory to give those super high doses of aspirin anymore. You just have to relieve symptoms. And we tend to have a low threshold of steroids when you have heart failure. And it's very important to educate the patient, the family, and ensure that the penicillin prophylaxis continues. That's very, very important. And steroids, they help in symptom resolution but do not prevent long-term complications. The real challenges are in ensuring that penicillin is received by everybody. The proper prophylaxis happens in every patient, at least if not lifelong, but till the appropriate duration as per recommendations. And somebody who has already established heart disease until the age of 40, at least it should be given. So to conclude, rheumatic heart disease and rheumatic fever may have declined in many low and middle income countries, but more accurately, it seems to be slipping out of our collective consciousness as the affected populations are marginalized. And that's where we really all have to be much more vigilant. Penicillin, of course, is very important in its control. But what I have done today is to really introduce you to some new concepts that have emerged over the last couple of decades. Thank you.
Thank you very much, sir, regarding this rheumatic fever and on the basic we should know about fever. And we would like to thank on behalf of Sri Lanka College of Cardiology on your wonderful lecture. Thank you very much.